Good evening, everyone. My name is Kate Esselen. I am one of the GYN oncologists here at Pathophysiology Medical Center. And I am very privileged and honored to present to you all tonight. Thank you to those of you who are spending this beautiful June summer evening with us. I tonight am going to be talking about low-risk gestational trophoblastic disease, which I think is a great topic because it's one just fascinating and one that crosses sort of all aspects of OBGYN care, from general GYN and obstetrical care, and of course, GYN oncology. So with no further ado, I would like to start with a case. If I can advance my slides. So this is a 38-year-old gravida 2 para 0010 who presented just over 8 weeks gestational age by her LMP with a positive pregnancy test. Her general OBGYN appropriately ordered a pelvic ultrasound where they did not see any intra or extrauterine gestational sac. And this is actually a true photo of this case. That is what we saw inside her endometrial lining. If I'm not sure you can see my pointer here, but there was a thickened approximately 3.4 centimeter mixed echogenic and hypoechoic area inside the endometrial lining. She had an HCG tron that was nearly 50,000. So as you all know from the title of this talk, it's no secret that we're going to be talking about gestational trophoblastic disease. And I thought it would be helpful to start by just defining what it is and classifying the different types. So gestational trophoblastic disease is a disease of the placenta, really. It is a tumor that arises in the placenta and has the potential to invade locally and also to metastasize distantly. So GTD, or gestational trophoblastic disease, is unique because it is a tumor arising not out of the host, maternal tissue, but out of the gestational tissue. Like any other tumor we talk about in GYN oncology, there are benign and malignant forms. So the benign forms of GTD are a complete hatidiform mole or a partial molar pregnancy. And the malignant forms are gestational trophoblastic neoplasia, can be of a variety of different histologic subtypes. So they can be invasive mole, choriocarcinoma, placental site trophoblastic tumor or PSTT, epithelial trophoblastic tumor, or more recently, they have added a categorization called atypical placental site nodule. So all of these are malignant forms of gestational trophoblastic disease. And today we're going to talk a little bit about both the benign and low risk malignant forms of disease. The epidemiology of moles in particular is a little bit difficult to fully quantify, or at least the incidence. Molar pregnancies are the most common type of gestational trophoblastic disease. They make up 80% of all the GTD that is seen. The true incidence of how often does this occur in pregnancies is very difficult to know. And over the years, it has sort of changed as reporting mechanisms have improved, or different country and tumor registry reporting mechanisms have improved with big data and information systems. But in Europe and North America, it's estimated that these molar pregnancies may occur in anywhere from 66 to 121 of 100,000 pregnancies, and might be more frequent in places like Latin America, Asia, and the Middle East, with reports up to about 1,300 per 100,000 pregnancies. The difference between complete and partial mole we'll spend a little bit of time talking about, but we do think their incidence is also slightly different. However, in general, we think we're probably underestimating the incidence. There have been some series that have actually done pathologic analysis on all sort of early pregnancy losses and done sort of analysis looking for complete or partial molar pregnancy tissue. And those have actually shown higher incidence of molar pregnancies than some of the epidemiologic data out of registry data. So a complete mole is thought to occur anywhere from 0.1 to 0.3% of all pregnancies. A partial mole, though, could occur up to about 3% of pregnancies. So what are the risk factors for molar pregnancy? Well, the extremes of age are probably the most common, if or equally common to having a prior molar pregnancy. So extremes of age put people at higher risk for developing a molar pregnancy. And extremes of age in this instance were mostly defined as anyone under 15, 15 years of age or younger, or over 40 or 45 years of age. Having a prior molar pregnancy actually increases your rate. So as we just saw, perhaps your rate of molar pregnancy may be as low as 0.01%, 0.01, sorry, 0.1, it's the end of the day. But up to a couple percentage points at most. But if you've had a prior molar pregnancy, you have a 10 to 15 times risk the general of the general population of having a molar pregnancy, maybe up to 1.5 to 2% chance. The recurrence rate goes up further if you have multiple molar pregnancies. So if you've had 2 prior, it can range from anywhere from 11 to 25%. Other risk factors commonly cited that I can even remember learning about in medical school, history of infertility or multiple prior miscarriages certainly increases your risk, maybe 2 or 3-fold compared to a general somebody who hasn't had these prior pregnancy history. Other thoughts are that there may be some dietary influences, particularly patients who have decreased intake of carotene or vitamin A may be at higher risk for molar pregnancy. But these are really the main, most commonly cited risk factors. Those patients who do end up with multiple prior molar pregnancies, we're learning there is sort of a familial syndrome, and we're actually even able to identify some of the genes that may be associated with this. So they are sort of a different population. So back to our case. So we have this 38-year-old G2P0 who's at 8 weeks. She had a pelvic ultrasound that shows not a normal pregnancy and a thickened cystic spaces within her endometrium, and her HCG is about 50,000. So appropriately, she was brought for a D&C, and at time of D&C, they saw hydropic villi. This is a gross picture of a molar pregnancy, a complete molar pregnancy. You can see the hydropic villi there grossly. This is obviously not our patient because it is a bivalve uterus and our patient just had a D&C, but it gives you a good sense of what that looks like grossly. And here is just a cartoon of what this pathology really is. So you can see here that under the microscope, those dilated villi look edematous. They're avascular. They're sort of enlarged and fluid filled. They can have big cavitary sort of spaces in them. And then surrounding these cavitary spaces, you see an increase in the cyto and syntrotrophoblastic layers, sort of the complexity of those tissues. That's the trophoblastic hyperplasia. So that's where these benign and malignant conditions arise. But how do they even come to be? So complete molar pregnancy. So here's a cartoon of what happens, to put it very basic. In a complete molar pregnancy, it's a diploid, meaning it has 2 chromosomes, but all the genetic material is coming from the father. So the ovum is actually empty and void of maternal chromosomes. And instead, either a single sperm or 2 separate sperm fertilize the ovum. With actually more common, we think, is the single sperm that then duplicates itself and becomes two chromosomes. So you can see there that these are the 2 sort of events that could occur to create a complete molar pregnancy. With a partial, and just to emphasize again, it's all paternal DNA in these complete molar pregnancies. There is some mitochondrial DNA, which we won't get into the details of the differences here, but that is still maternal because it is the maternal ovum. The partial moles on the other side, on the other hand, represent sort of similar fertilization events with either 1 or 2, shown here as 2 sperm, and there is still retained a single chromosome from the mother, or not a single, but a haploid from the mother, and then you get this triploid pregnancy that is a partial molar pregnancy. And sort of understanding this, which I realize is review for many people here, helps us understand why what we see on pathology and potentially the biologic behavior of it is so different. So with a complete molar pregnancy, there is no fetal or embryonic tissue because you only have one parent's DNA and you cannot create the embryo with that alone. The partial molar pregnancy, however, because you have both maternal and paternal DNA, you can see fetal parts or embryonic tissue present. In complete molar pregnancies, you see a significant degree more of the hydropic villi, and it may only be focal on a partial mole. Similarly, the trophoblastic hyperplasia of those trophoblastic cells is much more diffuse and widespread in a complete mole, whereas it's much more focal in the partial mole. P57 is a relatively new way of differentiating our molar pregnancies from complete and partial. Essentially, it's a cyclin-dependent kinase inhibitor, which is not important to remember, but what's important to remember about it is that it's actually a paternally imprinted, meaning it comes from the paternal DNA, but it can't be expressed unless there is maternal DNA present. So therefore, it makes sense that the complete mole, you would not get any staining for P57 if you stain the tissue with markers for this, because there is no maternal DNA present to express this. Whereas in a partial mole where you have both paternal and maternal DNA present, you're going to see P57 staining. So this really has become more important to have a test, several tests, but this test to sort of differentiate the two, because as is probably not a surprise to most people in this audience, we are seeing less and less of sort of the late presentation of molar pregnancies due to earlier access to ultrasound and earlier diagnosis of these. So sometimes the gross pathology is hard to differentiate. So again, the other way we can look at the tissue pathologically is doing cytogenetics on it to sort of see, is it a diploid or a triploid, and whether or not that sort of automatically tells you if it's a triploid that it should be a partial mole. The reason this is important, though, is because the risk of GTN is significantly different between complete and partial moles. So with a complete mole, and again, GTN is the malignant grouping or malignant version of the gestational trophoblastic disease. So with molar pregnancies, both complete and partial, they're benign. The risk of then subsequently developing a malignancy or an invasive disease related to this is about 15 to 20% for a complete mole, but only up to about 5% for a partial mole. So that has implications into how we follow these patients and what we do for them at diagnosis. So our case, our 38-year-old had a complete molar pregnancy. Here is a histopathologic example of that. And you can see the hydropic villi and the trophoblastic proliferation. If it was on higher power, that might be easier to see. So getting back to sort of how we got to the diagnosis, I just wanted to take a moment to think about how we approach patients as we are thinking about their initial management with a DNC. So in our case, clearly not a normal pregnancy. We didn't know yet that we had a molar pregnancy, but that was on the differential prior to going to the OR. And so preoperatively, there's a few things if you're concerned about a molar pregnancy that you should always be thinking about and doing if you're highly concerned. And if it's an advanced pregnancy, you should be doing all of these, or an advanced molar pregnancy, a pretty clear diagnosis from the ultrasound, you should be doing all these things. So you have your pelvic ultrasound. You want to get sort of a more comprehensive set of labs than you might get for a sort of a routine missed AB. You want your HCG preoperatively, so you know where you were starting before you evacuated the uterus. You want to get a CBC, liver, renal, and thyroid functions. We're not going to spend, as I mentioned, a lot of time talking about those classic presentations of molar pregnancy that presented with hyperthyroidism or preeclampsia due to sort of the advanced and high levels of circulating HCG and those effects, because that's not often what we see and not what we see in this case, but I'm happy to talk about those at a different time. The other thing you want to get is coags, and type and screen, or maybe even a cross match if she has a significant amount of disease in her uterus. There's a very high risk of bleeding from these DNCs. And then you do want to consider a chest x-ray. If your molar pregnancy is high on your differential, it's part of her workup, and she should have a chest x-ray to rule out metastatic disease. Intraoperatively, it's helpful to think about having ultrasound guidance there. You want to do this with both the ability to do a suction D&E and a manual DNC. The suction, just like any other, the technique is just like any other D&C or D&E you do, usually dilating up to about the gestational age, or depending on the size of the contents of the uterus, and doing all of this under ultrasound guidance to, one, reduce your risk of perforation, or at least observe if there is any concern for perforation, and two, to sort of evaluate for emptying of the cavity. It's a good idea, given the higher risk of bleeding and often the larger uterus that you are performing this procedure on, to consider using urotonics almost automatically. You could start an oxytocin drip right at the beginning of the case with your anesthesia colleagues and have other urotonics available to you, and be prepared after evacuation for some atony and to do uterine massage. Post-operatively, you want to make sure, if you had your type and screen, that you know whether or not your patient needs ROGAM, which they should be given. You want to look at the contents of the pathology, because sometimes, in spite of what I just showed you, it is difficult to make the diagnosis. You want to look for any evidence of hydropic villi, fetal parts, sort of get a sense of what you're seeing there. These patients are at much higher risk for cardiopulmonary complications than a non-molar pregnancy, D&C or D&E. These patients can develop sort of early in diagnosis. If they're diagnosed in the first trimester, this is incredibly rare. But if it's a second trimester D&E, up to maybe 2 to 3% of patients can develop significant cardiopulmonary symptoms that might present as chest pain, dyspnea, tachypnea, or tachycardia. And this respiratory distress you may observe is often thought to be attributed to trophoblastic embolization that happens at time of this D&E. But other things could cause it too. If there was a hemorrhage and there's massive fluid shifts and resuscitation, that could obviously lead to respiratory distress. Other conditions like the hyperthyroidism or preeclampsia, you can get a sort of high output congestive heart failure from that. So these patients, particularly the ones who might be in their second trimester at diagnosis and at time of D&E, should be monitored a little bit more closely than many of our other young, healthy women having a D&E. The last thing that you should definitely have on be thinking about is, what is your patient going to do for contraception? If you are at this point highly, based on your inspection and other preoperative workup, concerned for molar pregnancy, this patient, as you know, is going to need some follow-up, which we'll talk about. And so therefore she must have some contraception so that she doesn't get pregnant again and sort of complicate the post-molar follow-up picture. So these are recommendations for what to do following a D&C for a molar pregnancy. And it's probably not a surprise to this audience, but it involves HCG monitoring primarily. It's one of our best tumor markers that we have in G1 oncology. So you're going to follow that marker very closely, at least until it goes down to normal. And you're going to do it on a weekly, we do it on a weekly basis. 1 to 2 weeks based on some of the guideline committees are fine. But you want to follow that all the way to normal or less than assay. Once you have reached normal, this is where it matters. If you know whether you had a partial or a complete molar pregnancy. If it was a partial molar pregnancy, you're fine to stop monitoring after you get one additional 1 month post-normal HCG. For the complete molar pregnancy, we recommend at least 3 months post-normal HCGs. Prior guidelines recommended up to a year or even 6 months for these, but essentially greater sort of compiling of all the data of post-molar follow-up has shown us that it is probably safe once you've gone to normal, and I'll show you some of this data in just a minute. The likelihood of developing then post-molar GTN is so low that it is okay to stop monitoring at a much shorter duration of follow-up. And again, I'll share that with you in just a minute. We already talked about your recurrence risk after a molar pregnancy being up to about 2% of a repeat molar pregnancy. And I did mention to you there are some of these genes you can see in the upper right that we're learning more and more about that may be associated with the familial sort of molar pregnancy, recurrent molar pregnancy patients. Other options for treatment, if you didn't do a D&C or this patient had completed childbearing, hysterectomy is considered an option for treatment. It's not usually the standard of care because it is more morbid and more intervention. And this, the vast majority of patients will resolve their molar pregnancy without needing a hysterectomy. However, there are times, and we'll talk about this later, where maybe excessive bleeding or patient's wishes make this the better choice for them. And we're going to talk a lot more about chemotherapy given in the setting of GTN, but again, we're still in the benign range of disease with just a molar pregnancy diagnosis. However, there are some people who feel or who have practices that incorporate use of prophylactic chemo at this point. So that's a single dose of chemotherapy intended to reduce that risk of post-molar GTN. And so the incidence of post-molar GTN is anywhere from 3 to 8% after a dose of prophylactic chemo, which, for your complete moles, who we think have a risk anywhere from 15 to 20%, that's a fairly significant reduction. However, it doesn't mean they get out of monitoring, and it could have side effects. And so most folks around in the Boston area that I'm aware of are not typically giving prophylactic chemo, certainly not to all comers. It might be considered in patients who you are very concerned you may not be able to follow up, or they won't be reliable in getting their weekly HCGs, or patients who might have a lot of risk factors for the development of GTN. And what are those risk factors? So after a molar pregnancy, we know that complete mole, as we've talked about, is a significant risk factor for the development of GTN, but there are some other risk factors, such as age greater than 40, HCG over 100,000 pre-evacuation. On ultrasound, it's not uncommon, especially as you get to higher gestational ages, to see theca lutein cysts on the ovaries. If those are measuring larger than 6 centimeters, that's considered a significant risk factor for the development of GTN. And again, often seen more in later gestational ages, but if your uterine size is significantly greater than the dating of your pregnancy, that might also be a sign that this patient is at higher risk for development of GTN. So those may be some reasons to consider a prophylactic dose of chemotherapy. So what I was alluding to earlier about the risk of developing GTN after your HCG actually goes to normal. And I think in the year since, I've been a trainee till now, we've gone from following it for 12 months after a molar pregnancy now down to 1 for partial and 3 for complete molar pregnancies. And a lot of that comes from this study and others that have shown that it is extremely unlikely to develop GTN after a normalization of your HCG. This is actually a meta-analysis. Included in this were almost 15,000 cases of partial molar pregnancy and about 18,000 of complete molar pregnancy. And so they looked at and they wondered, is there any risk to those patients who have sort of shorter time to normalization versus longer time to normalization of their HCG? And they divided it by the 2 different types of molar pregnancy. And in fact, there was a difference, not only by the type of molar pregnancy, but also by the duration in which, or the amount of time it took for the HCG to normalize. So with partial molar pregnancies, and again, this was a meta-analysis including nearly 15,000 partial molar pregnancies. If your HCG normalized in under 56 or really over 56 days, the risk of you then developing a post-molar GTN was 0.02 or 0.03%. So incredibly small. And that is why guidelines have sort of moved with partial molar pregnancy. Once you're normal, you're normal. It is very unlikely, not impossible, but very unlikely you're going to develop GTN. And so it is okay to get a 1-month post-normalization follow-up, HCG, and then stop following. For a complete molar pregnancy, those risks are a little bit higher, as you'd expect, because the risk of post-molar GTN is higher. And so in patients, however, who normalize in under 56 days after a complete molar pregnancy, their risk is about the same as that of a partial mole. So really quite good at 0.03%. However, those patients that go to normal after or longer than 56 days, there is a slightly higher risk of developing GTN. Those patients with a risk of 0.3%. So that's still well under 1%, still extremely unlikely. But it is why there's slightly more monitoring for after a molar pregnancy than after a partial molar pregnancy. So the presentation of these patients who do develop GTN, so they develop the malignant form of gestational trophoblastic disease. I wanted to sort of touch on what sort of their presentation might look like. So their prior pregnancy event, everyone needs to have had a prior pregnancy event, as we've been talking about, is most often a molar pregnancy, either complete or partial, and that's at least half of all GTN comes from molar pregnancies. And that's why we follow those women so closely. However, it is completely possible to get to have GTN following any other type of pregnancy event, including a miscarriage, a termination, an ectopic pregnancy, or a term or preterm delivery, with about half of the remaining being made up of those early pregnancy losses or gestational events versus the later term ones. And so certainly for molar pregnancies, the most common way we diagnose it is with a rising or plateauing HCG, and we'll talk about the details of how we make the diagnosis. But for these other presentations, it's more often found with symptoms, most commonly being abnormal vaginal bleeding. However, you can get symptoms if you had metastatic disease from almost any of the sites. These tumors are highly vascular, and bleeding tends to be how they show their colors, with sort of events, bleeding events in the lungs, in the brain, vaginal mets bleeding. Other sort of more extensive pulmonary metastases can cause significant pulmonary symptoms, or a brain met can cause sort of compression or secondary neurologic signs from its effect in the brain. So any of these presentations are possible for GTN. Our patient, as we were talking about earlier, was being trended with her HCGs following her evacuation in September. And so she then went on to have an appropriate decline after her DNC with an HCG under 400. It had peaked just before her DNC at almost 80,000. And then it continued to decline appropriately for a period of time. This is just a note on her pathology. It did come back sometime in this interim showing a complete molar pregnancy. It was a diploid pregnancy, cytogenetics were done, and P57 was absent. So all very consistent with a complete mole. But you can see here that the HCG after the end of September, so about a month after her DNC, started to go in the wrong direction. So there's sort of three specific ways that you can diagnose after a DNC that you might for a presumed molar pregnancy that you might diagnose GTN. So the two HCG related diagnoses are either a plateau or a rising HCG. And I always found these incredibly confusing to remember the details of exactly. So an HCG plateau, and I don't have it up there on the slide, but essentially means it can fluctuate about 10% up or down from the prior value. But if it does that for four consecutive blood draws, which is actually only a 3-week period, if you think about it, days 1, 7, 14, and 21, then you meet the criteria for a diagnosis of GTN. If the HCG rises, on the other hand, more than 10% from one value to the next over a 2-week period, so that's 3 total values at day 1, 7, and 14, then you also meet the diagnosis of GTN. And finally, if on your final pathology from your DNC, you have a choriocarcinoma or even a placental site trophoblastic tumor or any other type of pathologically diagnosed GTN, that would also meet criteria. So here's our patient's HCGs. There are 3 of them. They rise they basically not quite or double-ish over the course of 3 values. So she met criteria. We often get referrals here in GYN oncology sort of with the first rise or the first plateau in the HCG. And certainly many of them do eventually meet criteria, but it takes a few weeks before you can do that. And while it's difficult to watch that or wait for that, especially with an anxious patient, it's incredibly important because if the HCG plateaus and then continues to decline, they are going to avoid chemotherapy. So we really need to meet all of these criteria in order to consider treatment. So what do we do once they've met criteria? So gestational trophoblastic disease, I should say, I thought I changed the slide. It should say neoplasia at this point which is a category of disease, but we are going to kind of repeat all of our workup that we might have done before the evacuation plus some. So you're going to repeat your physical exam. This is incredibly important, and I'll talk about why. You're going to get a CBC again. You're going to get renal and hepatic function tests, also thyroid test. You're going to type them and get an RH status. You're going to measure your HCG, which is how they got here. And then for imaging, all you have to do if you don't have any major concerns based on any of the workup to the left of the slide is a transvaginal ultrasound again and a chest x-ray. Now, if they're presenting with widely metastatic disease with pulmonary symptoms, neurologic symptoms, then of course you would do more workup. And things that have been described or are recommended, a chest CT, if you've got pulmonary symptoms, it's actually going to pick up in patients who have normal chest x-rays. It might identify micrometastases in about 40% of patients with GTN. You would get an abdominal CT as well, looking for any intra-abdominal metastases. A brain MRI, certainly, if they have evidence of other metastatic disease, they need the brain MRI. And you could consider a PET scan. So this is all the workup that goes in once they've met criteria before they've started treatment. And just to talk about one of the very unique features of this disease is just how quickly and how far it can metastasize, unlike many of our other gynecologic cancers. So of patients who have metastatic disease, 80% of them will have lung mets. The next most common site of metastasis is the vagina. So that's where your exam is super important, because you have to identify wherever their metastatic disease is in order to know how to best treat them. So a good vaginal exam, really looking into the fornices. I've seen a few cases with vaginal metastases, and they often, at least the ones I've seen, appear like small blue cystic tumors, but more blue than anything else you normally see. They can be quite large or small. The inclination, which is a good one usually of a GYN doctor, is to biopsy anything that looks abnormal. But in the case of gestational trophoblastic disease, please do not biopsy anything. As mentioned, bleeding complications are incredibly common from metastatic disease, and you will end up with likely a hemorrhage in your office. So do not biopsy any of these lesions, but do note them, count them, measure them, because it's a way you can follow her response to treatment. Pelvic mets are about 20%, and then less commonly brain and liver mets. So if you have mets to the lung or the vagina, it is reasonable to kind of get the full workup and look for these other metastatic sites, because often it goes to one of those two places first, but then it may also be in the brain, in the liver, etc. Much less common in other places like the kidney or spleen. So important to know where it is, because that's how you stage it, and also how you give it a risk score. So first we'll talk about the staging. The staging is actually one of the simplest and cleanest of our staging systems in GYN cancer. Stage 1 is simple. It's just confined to the uterus. Stage 2, it involves either the adnexa or the vagina. Stage 3 includes lungs and any other, genital tract involvement. So stage 3 is very simple. It's either in the uterus or any surrounding structure, and then it's up in the lungs. And stage 4 is everything else. So it's a fairly simple staging system, but of course we are never satisfied with simple in GYN oncology. So we created this risk score, which is actually almost more important than their stage at determining what kind of treatment they need. So this is the World Health Organization, WHO risk score, and every single patient needs to be staged with that initial workup, which includes your exam and those other tests, and then given a risk score. So let's do that for our patient here. So her HCG, as mentioned, had risen up to about almost 1,300. The rest of her lab studies were completely unremarkable. We did repeat her pelvic ultrasound, and it was also pretty unremarkable. Normal size uterus, endometrial thickness of 4 millimeters. Ovaries were normal without cysts, and there was no free fluid. Her chest x-ray was also completely normal. So again, she's 38 years old. So her age, she doesn't get any points for that. That first column on the left is 0. Her prior pregnancy was a molar pregnancy. She also gets 0 points for that. It was pretty recent, her molar pregnancy, less than 4 months prior, so at 0 points for that. The only thing she gets any points for is her HCG over 1,000. So she gets 1 point. So her risk score is, she's a stage 1, confined to the uterus with a risk score of 1. But then, just for fun, let's redo her risk score just to see how it moves around with some other potential findings. So now let's change her age to 45, or maybe give her a few pulmonary metastases, or change her prior pregnancy and timing from prior pregnancy. So with that first case, if we bumped her age up to 45, well, now she has a risk score of 2. So not significantly increased, but it shows you the importance of age, again, in the risk score. This time, we've taken her back down to 38, but we've given her 4 lung mets. In almost every other disease we take care of, if we see lung mets, we get very concerned, and the prognosis is not great. But here she is, she's got 4 different metastatic lesions in her chest, and her risk score just goes up as if she was 45 years old. Her risk score is also 2. This final case, though, modifying it with a full-term vaginal delivery about a year ago, suddenly she gets 2 more points for that term delivery, and she gets 2 more points for that year-long interval between this and the diagnosis of GTN. So she's gone from a risk score of 1 all the way to 5. And this is sort of a summary of where we are. But ultimately, all 3, and by the way, that third patient, not only did she have her risk score is actually 2. Sorry, I didn't adjust that slide appropriately, but her stage is 3 based on the pulmonary mets. But all 4 of these scenarios are low risk disease. And so the definition, to be more precise, of low risk gestational trophoblastic neoplasia is stage 1 disease confined to the uterus, or even more advanced stage disease, 2 or 3, as long as everyone has a WHO risk score of less than 7. We do think that there's sort of an intermediate risk or slightly higher than low risk group with WH scores about 5 or 6, and we'll talk a little bit more about that in a few minutes. And we think that this is important because it may affect our chemotherapy choices for these patients. But essentially, others have really looked closely at what specifically might put people really at high risk for needing more aggressive chemotherapy treatment. And it has a lot to do with where their HCG is prior to evacuation, whether or not they have metastatic disease, and metastatic or any choriocarcinoma certainly increases their risk a lot. So even though you could have a patient with choriocarcinoma with a risk score under 7, you might want to treat that patient a little bit differently. And so we'll talk about that in a few minutes. But for these patients who are our low risk disease patients, so most of them have a WHO risk score between 0 and 4, we can treat them with low risk chemotherapy. So there are 2 main options, although you'll see there are many different ways to give them. So this is a table sort of summarizing all the potential chemotherapy options that have been studied and reported on for low-risk gestational trophoblastic neoplasia. And I should mention here, you'll see on the right, the primary remission rates, which are incredibly high for single-agent chemotherapy in this disease. And in fact, chemotherapy and effectiveness of chemotherapy was first discovered in GTN of all the cancer types. And the first sort of potential cure from chemotherapy came from GTN, if you look back in sort of oncologic history. So again, the 2 agents we use are methotrexate or actinomycin D. There are some key differences between them, but these are sort of a laundry list of all the different regimens that have been studied. I just want to point out the one regimen that does appear to be much less effective is the weekly IM methotrexate dosing that may be up to 74% effective in best case scenario, but it's significantly less. All the rest of these have primary remission rates in the 80 to 90% range. So it is significantly less effective and is not really strongly recommended. But what do you do with all these different regimens? How do you decide what these patients are going to get? And it is hard to give an otherwise young, healthy woman who wanted to be pregnant potentially and to tell her she needs chemotherapy. And so it is tempting to want to give that weekly methotrexate, which isn't too different from what we do for ectopic pregnancies, but it's really not as effective. And so, but then how do we decide of those other regimens, which one to use? And so methotrexate or actinomycin D. Of course, anytime we have a choice between 2 highly effective agents, we look to the literature to try to differentiate which one might be best. We did actually try to study this. I'm going to draw your attention to the bottom of the slide with a GOG or NRG study, NRG 275, that was actually unfortunately closed due to slow accrual. It was accruing between 2012 and 2016 and only got about 57 patients, and they were randomized to either an actinomycin pulsed actinomycin D regimen versus a multi-dose methotrexate regimen. And as you can see there, the response rates, though certainly the study was closed early and are not powered to truly detect any differences, but are very equivalent to 79%, 88% for methotrexate. And then going up to the middle of the slide, there has been an effort to combine all these smaller trials reporting on effectiveness of these regimens into a meta-analysis. There was one published in 2016 that included 7 randomized control studies. And of that, there were about 667 patients, and they did show a statistically significant higher cure rate for actinomycin D as compared to methotrexate. And so this has led many centers to consider using actinomycin D before methotrexate, which had sort of been the original bias to using methotrexate. The reason for that was that methotrexate, the ease of administration is much less. It's not an actinomycin D is an intravenous medication, requires an infusion center. Methotrexate can be given IM, and actinomycin D is also a little bit more toxic with some more severe sort of side effects. Notably, it is a vesicant, so any extravasation onto the skin is incredibly toxic. It can cause some alopecia, and it certainly is associated with nausea. Methotrexate, many of you are probably familiar because we use it in other places. The most common sort of side effects are that patients experience would be like mucositis, watery, dry eyes, and soreness at the injection sites, but is really otherwise pretty well tolerated. They both can have hematologic effects. They both are excreted by the kidney. And the one notable difference is methotrexate is more hepatotoxic. So if you have a patient with significant liver disease, that might be somebody you preferentially choose actinomycin D instead. But these sort of data don't answer the question of which one is better. Both are really good choices. Both have incredibly high cure rates. And so our practice here and also at the New England Trophoblastic Disease Center where I trained is to use the multi-dose methotrexate regimen, which is an 8-day regimen where you're given 4 doses at 1 mg per kg of methotrexate IM. On your days 2, 4, 6, and 8, you take folinic acid or leucovorin rescue pills to sort of mitigate the effects of methotrexate on all your normal cells. And that's repeated every 2 weeks. And we'll talk about how you decide how many cycles and how long. There are some alternative regimens. As you remember, that table had multiple different methotrexate regimens. So there's some fixed dosing regimens that you could use. All of these regimens, you follow patients until their HCG goes to normal, and then you continue them with what's called consolidation treatment cycles to make sure that the disease doesn't come back. And it's always very hard to tell your patient when their HCG is now less than assay that you're still going to give them 2 or even 3 more cycles of HCG. And our practice is to do 3. And with this regimen plus the consolidation, the remission rate is nearly 100%. So again, as I mentioned, complete remission means you have at least 3 consecutive weekly HCGs that are less than assay or normal. However, even at this point, we think that there's probably at least 100,000 tumor cells left, even though the HCG is normal. And that's why we recommend consolidation treatment cycles. And there was one study that actually compared the difference between 2 and 3, which is very helpful to me in counseling patients because it does give numbers and put in perspective what that extra 2 weeks of treatment, because it can take, anywhere from, if you're lucky and you get, remission after 1 to 3 cycles, then you're still doing another 3 more. So that's 6 cycles of treatment or 12 weeks. And many patients need much longer than that. So you need to do some convincing sometimes to get them through those last few consolidation cycles. And so our colleagues across the street and in Brazil actually looked at a large number of patients, 350 patients who got 2 cycles of consolidation versus 600 who got 3. And they showed that the disease relapse rate was statistically significantly different between the 2 groups. So about 8% in the 2 consolidation cycles and 4% in the 3. So that's half as many people recur. Of course, those numbers are small, and there may be patients who are willing to take on that 8% risk to avoid more treatment. But it is an important point, and it is why if you meet patients that you send to us and we treat them, why we're doing 3 additional cycles of chemotherapy after normalization. So we have about 15, 20 minutes left. I do want to leave time for questions, but I thought we could do one more case just to illustrate some of what we talked about, make a few additional points, and then open it up for questions. The next case is a 43-year-old G3P1 who presented at 12 weeks by her LMP, and she had a fetal pole visualized on her ultrasound, but no fetal heart rate. She ended up undergoing a D&C, and the pathology showed a partial mole. There were dilated villi, rare central cisterns, and there was triploidy on cytogenetic analysis. So just to have you all think just for a moment to remember the beginning of the talk, if they sent a P57 or did a P57 stain on this tissue, what would you expect? So it's funny to talk to yourself and then answer your own question, but as a partial molar pregnancy, you have both maternal and paternal DNA present, so you're going to see the P57 stain. It will be present, and that will again confirm the partial mole diagnosis. So she had her D&C, and then her HCGs were trended. And in this case, they sort of started out around, I'm trying to remember, her D&C, after her D&C, they started declining, and you can see they went down from a peak of almost 3,100 down to the mid 400s. And there, beginning in October, you can see that the values are starting to they're not really doubling, but they're plateauing. And so again, you need 4 distinct values 1 week apart in order to demonstrate presence of GTN. And so she met it only after her 4th HCG. So she was referred and had a workup. Oh, I forgot to mention that she did actually, her outside providers, as they saw that HCG going up, gave her a dose of methotrexate. That's not quite the idea of the prophylactic chemotherapy dosing, which you give right after evacuation, but it was given, and so we have to factor that into our subsequent evaluation. Her presentation was also notable that she had some pretty significant ongoing bleeding and now her rising HCG levels. And so on exam, she had blood in the vault that was cleared away, not hemorrhaging, but significant. And in the posterior cul-de-sac, there were 2 tiny 2-millimeter sized blue nodules that were immediately posterior to the cervix, directly in the posterior fornix. They were palpable and visible. Otherwise, her uterus was enlarged but mobile, and there was some adnexal fullness on the right. So we obtained another HCG, which at this point was 719. The rest of her labs are completely unremarkable. Her pelvic ultrasound did show an enlarged uterus, almost over 11 centimeters, but was markedly distended with a 6 centimeter by almost 6 centimeter cystic sort of endometrial mass. There was a moderate vascularity associated with it. The ovaries were actually normal, and there was no free fluid. So her chest X-ray did not show any evidence of metastatic disease. So we're going to quickly calculate. So if you recall, I didn't put it in here, but the staging system, any potential metastatic disease, and unfortunately it's not safe to biopsy and confirm this completely, makes her in the vagina, makes her a stage 2. So she's already a stage 2, but now her WHO risk score. So this patient is older than 40. She had a prior molar pregnancy, so both partial and complete don't get any points. It was within 4 months, so it was no points for interval from index pregnancy. Her pre-treatment HCG is only 700, so it's less than 1,000, doesn't get any points for that. However, her uterine tumor, which is included in the largest tumor size variable, is over 5 centimeters, so she gets 2 points for that. She doesn't have any known metastatic disease in the lung, spleen, kidney, GI tract, brain, or liver. She doesn't get any points for a vaginal MET. However, she does get points in the number of metastases. And so for this, she had 1 to 4 METs. She had 2 small nodules. So we give her a 1 for that. Now, the bigger question is whether or not we should give her points for that chemo. She didn't really get sort of full dose chemo, and what to do with a prophylactic dose of chemo is not generally thought to be included. But if we want to, just for sake of argument, see how that would change her risk score, she would go from being a 4 up to being a 6. And so, as we mentioned, 0 to 4 on the risk score, it's very clear that's low risk GTN, and we can treat it with a low risk GTN regimen. But if you do see prior treatment, that could bump her up to a 6, which then puts her in the category where we're a little bit more worried about her potential for resistant disease and maybe needing more aggressive treatment. So we're going to call her more likely a 4 than a 6, but you could see how they might score her as a 6. Anytime they're sort of on this cusp in that 4 to 6 range, I do kind of think about these other risk factors for chemo resistance. And she really doesn't have any of those because, again, she's a soft 6, if at all. She does not have choriocarcinoma, and her HCG is incredibly low. So I do think it's really safe to consider this a stage 2, low risk, probably more of a stage WHO score 4. But the one thing that is notable about her presentation, unlike our first patient, is that she's bleeding. And so you do kind of want to help her. It's pretty significant, saturating pads throughout the day. So is there a role for a second curettage? And I'm just going to share briefly some of the data around this. She has a big tumor inside her uterus. There was a group that sort of studied second curettage for low risk gestational trophoblastic neoplasia. So they enrolled patients who had a mole following their initial curettage. So this is their sort of GTN presentation. Their HCG was still elevated. They had non-metastatic disease, no evidence of METs anywhere. So our patient, if we call her vaginal METs, may not have qualified. But her risk score would have at a 0 to 6. And they essentially did a second curettage and showed that about 40% of those patients, and again, this was only about 60 patients, were cured, meaning their HCGs then went to normal and stayed normal without needing any chemotherapy. So for certain patients, this may be an option. But they did see that there was a subset of patients who did not get a cure almost universally when their HCG score was, where their HCG was over 100,000 or their risk score was 5 or 6, nobody was cured with the second curettage. So our patient doesn't quite fit into this. But in general, I just wanted to sort of review, when I think about GTN and a second curettage, I don't routinely do it. However, if they are having significant bleeding and there is residual tissue within the uterus, I think those are patients to consider it. Other series and the ones I've just showed you, which was 40% remission rate, anywhere from 20 to almost 70% remission rate reported in the literature. It's a high risk procedure, just like the first one, high risk of bleeding, high risk of uterine perforation. 8% is the highest risk that's quoted. Other studies I've seen closer to 1 to 2% risk of uterine perforation. There was a cost effectiveness analysis that actually said it's only cost effective to do a second curettage if you get a 98% cure rate. So we're clearly nowhere near that number. And that's sort of why I don't routinely offer it. But in somebody who's bleeding, who has intrauterine disease or has highly motivated to avoid chemotherapy, knowing they might still get it, it's reasonable. And there's a series that does show HCG normalizing a little faster if you evacuate the uterus. So in our 2 cases, both patients received 8-day methotrexate. Each one received, case 1 got 3 cycles till normal, case 2 got 2 cycles, and then they got 3 consolidation each of them. Neither one of them experienced any significant toxicities, and both did very well and continue to do well. So how do we follow them now? So it is recommended that once you've had chemotherapy for your GTD or GTN in this case, that you do get 12 months of surveillance HCG. Any new pregnancy event is going to be worrisome to be a recurrence. And so it's not really recommended that patients go off birth control before that time. And we strongly recommend birth control so as not to confuse the issue. That said, sometimes these patients are at extremes of age and very eager to get pregnant. And so it is tough sometimes to convince your patients to do 12 months of monitoring. And similarly, it can be a very emotional and psychologically challenging for patients who are eager to get pregnant. And as mentioned earlier, a lot of these patients have a history of infertility or prior miscarriages. And so these are patients who are high risk for depression and anxiety, and that should be part of your sort of ongoing evaluation of them. Future pregnancy events for all of these patients, they should be counseled that if you have, or if you're meeting a patient who has a history of a molar pregnancy or a molar GTN, they need an early ultrasound at 6 and 10 weeks, or somewhere between 6 and 10 weeks. They always should have their pathology sent, or their pregnancy tissue or a placenta sent to pathology to look for potential gestational trophoblastic disease. And HCG, no matter what the pregnancy event is, if it's a miscarriage, a termination, an ectopic, or even a term delivery, you should remeasure that HCG at 6 weeks after pregnancy, because again, they're at higher risk for repeat molar pregnancy. But the good news that you can share with your patients who are interested in becoming pregnant is that many women, most women, will go on to have a totally normal pregnancy following their molar pregnancy. And the rates of sort of live, pregnancy attempts and live term births afterwards are very high. There are about population-based rates of miscarriage and prematurity. There is, again, population rates of stillbirths, and these are after pregnancy who got chemotherapy for their gestational trophoblastic disease. Rates of repeat molar pregnancy, this is all from the New England Trophoblastic Disease Center, are about 1.5% in this group. And the good news is their rates of congenital anomalies, these are women who have had chemotherapy now, are similar to that of the general population. So my final slides are just to remember that for low-risk disease, there is another option aside from chemotherapy and DNC and chemotherapy or possible second curettage. You can consider hysterectomy. It's not commonly performed because our chemo is so effective and so many women wish to retain the ability to have future children. But in women who are done childbearing, as primary treatment, this can achieve about an 82% cure rate. So what should be noted is that it is not 100%, and therefore you must trend their HCGs after hysterectomy. They are not cured definitely, and that's probably because there was microscopic metastatic disease elsewhere at time of diagnosis. It's also a treatment option for patients who have chemo-resistant disease. Usually we go on to treat them with a second single agent if they're low risk and get a very high cure rate, but another option might be to do a hysterectomy in that setting. Again, the cure rates in the secondary setting are also about over 80%. And then for patients who are hemorrhaging, who you cannot control the bleeding with other methods, it is reasonable to consider a hysterectomy for those patients as well. And these percentages here are, in the series that look at sort of hysterectomy for low risk GTN, a third to, almost half are primary treatment or chemo, and then the other chemo-resistant disease. It's pretty rare to need to do a hysterectomy for bleeding. So that is all. Thank you all so much for your attention. Again, I'm honored that you came. I want to just again mention, I didn't totally say this at the beginning, but I'm sorry for the change in day. That was an unscheduled OR case, and so it was a little bit last minute, and I apologize. But thank you so much to those of you who came and those of you who are still listening, if you're watching this online. And I will take any questions. I see some friends in the participants. And while we wait and make sure nobody has any questions, you see here, this is our G1 Oncology division in its current state. That is Dr. Leslie Garrett and Dr. John Dalrymple and Dr. Joe Totino and Dr. Drew Wishart, all on an early morning Zoom. So in case you're wondering who those faces are that you might refer to. All right. So it's 6:01. I think I will let everyone get out and enjoy the rest of this day. Thank you again so much for your attention.